So we have, right now, we're going to have Greg Marchildon, who's going to speak on personal reflections on a research agenda for northern and rural health. And then we're followed that by Jim Rourke. So Greg Marchildon, Greg, you want to come on up? He's the Ontario Research Chair in Health Policy and System Design within the Institute of Health Policy Management and Evaluation. But I think he is well known for people. He's come from, well, had a number of different jobs, but I guess most recently we recruited him from Saskatchewan. So, Greg.
Well, thank you very much. You know, it's late in the afternoon. I can see that the room is thinning out. And I'll declare victory if I can just get even one small laugh out of you. And I will also make sure that you, at least half of you, put your cell phones away for 10 minutes, and I'll declare victory on that as well. But I know it's late. I know that some of you have been pulled away for very good reasons. A number of the students have had to leave because of the fact that they have classes. And I know that as well that some of you have your personal work that's pulling on you. So I'm going to be as short as possible. I was asked to talk about a health policy research agenda for northern and rural health. And I'm going to try to do this in a way that's easiest for me, actually, and that is basically to provide some personal reflections going through some of my own experiences in this area over the last 20 years. And then I'll try to draw it together very quickly. I'll start with Saskatchewan, where I was and worked as a deputy minister in the 1990s. And I arrived in Saskatchewan for my academic post, first time I'd ever worked in government, and there I was. As a deputy minister in an enormously steep learning curve. And the government that I worked for was very aggressively addressing its accumulated debt and bringing its deficit down to zero. It had also engaged in a series of quite radical health reforms, including being the first province to really introduce regionalization. And of course, other provinces followed suit very quickly after. But there was a problem that the government faced right off the bat, and that was that there were a number of rural hospitals that were really not being used for the purpose for which they'd been built and intended. And they really didn't make sense, but the government knew that if it gave the task to consolidate and to reduce the number of hospitals in the province, that the regional health authorities would be destroyed because this was something, of course, that was very important to rural people, not for health reasons, but largely for employment reasons. And most people just avoided the hospitals. Their spouse might work in the hospital, but they would go to the nearest large center for any major sort of acute care. And so there was a problem. And it was dealt with in a very short period of time with the closure or conversion of 52 rural hospitals. To the best of my knowledge, this did not occur anywhere else in the country to this level. But you should know that the health system outcomes actually improved as a result of this because the quality of care in these hospitals was extremely low. And in places where they had been converted to wellness centers or to long-term care facilities, to some extent, they were already playing the role of the latter. It actually increased services in some of these communities. But politically, there was an enormous price to be paid for this. And almost all of the rural members that were in the government that I worked for were defeated in the very next election. And so you can't separate public policy from politics, and I'd be happy to discuss that at further length after in the question period. The other experience I had at that time was the negotiation over something that was then called the Black Lake Hospital, which became the Athabasca Health Facility. And there was some discussion about how Medicare ends at the where the reserve begins in Canada. And in fact, that should not be true, because Medicare applies to residents, all residents of every province and territory. It is not based upon whether you are Indigenous, an Indigenous person who is a registered Indian and using the legal language, or an eligible Inuit, again, using the legal language. And so provinces are responsible for basically providing all medically necessary hospital and medical care services to all residents. But we had this difficulty in that it made sense to build the one hospital in the very far north on reserve land. And so there was this protracted negotiation, tripartite negotiation between the federal government, provincial government, and the Dene First Nations of that region over this. And it finally did result in the building of a hospital that basically became more of a complex health facility, very similar to what was described earlier today in terms of a cluster of health services. And in this sort of configuration, both the federal and provincial governments contributed. And the funding came from both orders of government. And out of that, basically, the same tripartite agreement constituted the origins of the Athabasca Health Region in the far north, with the Dene First Nations being in the driver's seat, but the funding largely being delivered from the federal and the provincial governments. And of course, even today, with the creation of a single province-wide health authority in Saskatchewan, the one exception is the Athabasca Health Region, because they did not want to tear apart that tripartite agreement. So you have one health region that's geographically based in Saskatchewan in the far north, and the rest is about to be managed by a single provincial entity. My next experience was as executive director of the Romanow Commission, and the two most ignored chapters in that report happen to deal with rural and remote communities and Indigenous health, chapters 7 and 10. There was virtually no comment on either of those chapters after the report was issued, and I'll tell you, because I bear the scars on my back, there was plenty of commentary on other parts of the Romanow Commission report. But in Chapter 7 on rural and remote communities, of course, the report highlighted the disparities of health between urban and rural and remote areas in Canada, the disparities in access, the need for increasing local provision of health services, and the recommendation for a rural and remote access fund that would encourage experimentation in terms of rural and remote delivery. And then in Chapter 10, on a new approach to Aboriginal health, the report recognized self-government actually as a determinant of health, and recommended the consolidation of federal-provincial funding to support Aboriginal health partnerships. These would be community-based voluntary organizations that would form through interested providers and or community groups, and they would be responsible for providing health services to a defined population. This population obviously would have to be rostered, but it would be open to non-Indigenous people as well who wanted to get that particular range of services provided in the way that would be defined by the Aboriginal Health Partnership. Of course, this recommendation went nowhere. And the federal government and provincial governments at the time simply did not want to talk about it. But it's something which should be considered because most of the options that we have either involve, and there are two extremes when you think about it. One is government provision, community health centers as we have in the territories, basically. There might be community input through boards, etc., but it's largely government-driven. And then on the other end of the spectrum, you have private for-profit professional delivery. And these are where professionals decide to set up, and it's done basically through a kind of a market mechanism. And there's nothing in between. And we talk about community-based solutions and community-based care, but we're a rather impoverished country when it comes to that. There's very little of it going on in the country, and we've not created the funding mechanisms to really facilitate it. But we've also talked about the fact that certain community members are overburdened with tasks, and there is obviously a challenge when it comes to this, but at the same time, I don't think that we've really exploited the full potential of that kind of community-based approach. The next thing is that I spent a number of years doing work for the government of Nunavut, but I wasn't, I didn't want to be a traditional consultant, so I entered into a contract with the government of Nunavut that my work would basically be published separately from the government, and that I could define that work to a large extent. So it became a review of the health system, but I was then asked by the government that since I was traveling around to all of the communities anyway, would I be prepared to do an inventory of health, human resources, and infrastructure in the territory, because they really didn't have that information at their disposal. Quite frankly, it was a bit of a pain in the ass to do that work. It was very detailed work, but it turned out to be valuable in terms of understanding the nature of the system. One of the unique aspects of Nunavut is that it's a single spout approach, and it's one in which even federal programs are administered on contract by the government of Nunavut. The government of Nunavut does not work with Indigenous health organizations. It provides those services directly. There's been a long-standing discussion about that, but the point is the government of Nunavut considers itself basically as a self-governing Inuit government. It is a public government. It must provide services to everyone, but it was created in 1999 with the idea that it would be a government for the majority of its residents who are Inuit. So it doesn't feel the need to work through Indigenous organizations. So you end up with a government that is able to, in a sense, put all the funding together and provide services in this way. Of course, population's very small, less than 50,000, so there's very limited secondary, tertiary services. In fact, almost all of it's centralized in Iqaluit, and I'll talk about how the rest is done in a second, but there are some secondary services as well in Cambridge Bay and Rankin Inlet. The rest operates through a very sophisticated referral and medical evacuation system. There are enormous administrative challenges and churn in the territory of personnel, which creates enormous problems. And I argued in this piece of work at the end that there is a policy connection that has never been fully taken advantage of between the determinants of health, at the administration of public health and primary care through the community health centers. And I felt that, that basically the public health infrastructure and the people involved in it could provide support to the community health centers through the appropriate surveillance, but then providing that data back to the community health centers so that they could identify the hot spots and deal with some of the anomalies community by community. Again, very difficult to implement such a recommendation in this environment given the churn of personnel. There is a much greater reliance on southern administrators and providers. I put that in quotations because some of those individuals are people that have lived in the territory for quite some time. But there is a policy to turn over as many senior positions to Inuit residents as possible. But contrary to Greenland, where almost everyone who's a provider in that system, including the physicians, are Greenlandic. Now, I can't say that they're Inuit. Most are Inuit, but they don't use a definitional system like we do. As long as you speak Greenlandic, which is basically a type of Inuktitut, and as long as you send your children to a school that is Greenlandic, you are considered to be Greenlandic. We take a different approach in Canada. But what it means is that most of the people providing services in Greenland are, in fact, families that have been there for a very, very long time, and there's a connection in terms of language and culture to the people receiving services, and there is not that connection in Nunavut. These are the medical air links, and as you can see, they're through 3 major centers. Exclude Montreal, that's more of a historic center, but the other centers remain very active. And you can see that this is potentially a very expensive system given the distances involved. And in fact, medical transportation, when you add in both federal and provincial costs, are the single greatest expenditure in that system. And Nunavut is the most expensive health system in the world, based upon a study that was done as part of a Circumpolar Jurisdictional Review. This study was done led by Q Young, and Susan Chatwood and I worked on the Canada portion of it. Some of the policy implications that came out of this major study of all of these northern jurisdictions was that, in fact, there were very novel health delivery arrangements in the various jurisdictions, in part because it was necessary given the spread of population, extremely cold climate, and the size of Indigenous populations, in many cases constituting a majority in some of these jurisdictions. There are 2 predominant models of primary care. One is nurse-based, that's true for Alaska and Canada, and one is physician-based, and that's true in the other jurisdictions, except for Russia, which has a kind of a third option, which was created in about the 18th century, which is the use of a provider called a Feldsher. And it is, this individual is neither a nurse nor a doctor, but is the predominant provider of medical services in northern areas. The other aspect of it is that in almost all cases, there were what we would call community health centers in the Canadian context. And there was, in most cases, an effort to try to have Indigenous providers, and in most cases, Even in cases that were physician-based primary care systems, there had to be physician substitutes at some point in terms of the health system. And of course, in all cases, increasing use of e-technologies. Again, in a study done with Q Young and Susan Chatwood, we then looked at what are some of the outcomes in terms of the 3 territories in Canada using amenable mortality as our indicator. These are avoidable deaths from preventable or treatable causes, and you can see the results here. Now, it is true, like when you look at all OECD countries or OECD subnational jurisdictions, there has been a decrease in the number of avoidable deaths over time, and that you would expect. So you're looking at 2 things. One, you're looking at the rate of decrease, and that's what's important. How does one jurisdiction compare to another? In this case, how do the 3 territories compare to each other, and then how do they compare to the Canadian average? And then the second thing you're looking at is the absolute number. And here you can see that Nunavut is quite different than the other 2 territories, much higher level of deaths that would ordinarily be avoidable if the proper, if it had been prevented or treated at the proper time. The next area I looked at, and that came out of my government experience, was the Canada Health Transfer and the impact of the Conservative government's change to the Canada Health Transfer that made it a pure per capita transfer, and the impact this had on various jurisdictions. And an argument